When kidneys fail, patients die from secondary collapse, hearts stop from electrical instability, or lungs drown in fluid. We track two trajectories. Chronic kidney disease follows a slow decline, while acute kidney injury is a sudden cliff drop demanding immediate intervention. This diagram highlights the glomerulus, the primary filtration barrier. GFR measures filtration speed, while BUN and creatinine track waste. Since CKD patients have low filtration, abnormal baselines are expected. Knowing this baseline distinguishes chronic stability from lethal deterioration. This vascular network requires 25% of total cardiac output to function. This makes renal tissue highly vulnerable to pressure drops, like in sepsis. Hypoperfusion starves these tissues of oxygen. This ischemia stops urine production, manifesting as oliguria, falling below 20 milliliters per hour. This sequence shows the clinical chain of events. Sepsis leads to a blood pressure drop, which triggers hypoperfusion and oliguria. Since the kidneys cannot excrete water, the volume backs up into the lungs, creating systemic fluid overload. Reversing this requires restoring volume through fluid challenges and forcing filtration with loop diuretics like Lasix. Success is measured by a return to a urine output greater than 30 milliliters per hour. Prerenal failure begins as a perfusion problem, but if flow is not restored, the resulting fluid accumulation turns it directly into an airway emergency. When the kidneys stop filtering, potassium accumulates rapidly in the blood. Because potassium regulates muscle contraction, we monitor the impact of this imbalance directly on the electrical rhythm of the heart. If serum potassium levels climb too high, the heart's electrical conduction begins to fail. You will see severely peaked T waves, followed by a dangerously widening QRS complex. Both are immediate warnings of impending cardiac arrest. The first priority is to stabilize the cardiac muscle. Administering IV calcium gluconate does not lower the potassium level, but it protects the myocardium from lethal dysrhythmias while you work to correct the lab value. Next, we shift potassium out of the blood and into the cells. Giving regular insulin alongside dextrose forces potassium across the cell membrane, immediately lowering the dangerous serum levels. Finally, we permanently remove the excess potassium from the body. This is done through sodium polystyrene sulfonate, or kayexalate, which promotes excretion through the bowel, or with loop diuretics if the patient can still produce urine. In a renal electrolyte crisis, fixing the threat to the heart always takes priority over actually lowering the lab value. These represent the two methods of long-term renal replacement. Patient A uses hemodialysis, filtering blood externally through a surgically created AV fistula. Patient B uses peritoneal dialysis, using an abdominal catheter to filter waste internally across the peritoneal membrane. Let's prioritize 4 renal patients. Quadrant 1 is a CKD patient with a creatinine of 4.5. Quadrant 2 is a post-op patient with 15 milliliters per hour of urine output and lung crackles. Quadrant 3 is a hemodialysis patient with a clotted fistula, and Quadrant 4 has BPH with urinary hesitancy. Patient 2 is the priority. While the other patients have chronic baselines or non-lethal obstructions, this patient's oliguria has already led to pulmonary edema. This is an active airway crisis requiring head-of-bed elevation, oxygen, and diuretics. These clinical judgments rely on 3 priorities. Airway and fluid status take precedence during overload. Cardiac stability remains the primary focus of electrolyte management, and acute, unstable changes always outrank chronic baselines. Protecting the renal patient requires monitoring the heart and lungs with the same vigilance as the kidneys themselves.